Hello, everyone. Have a nice Friday. My name is Dr. Abdullah. I'm going to try to present about the EMBA kidney trial as the empagliflozin in patient with chronic kidney disease. So probably as you already know, chronic kidney disease is a major concern and public health concern. 1 out of 10 patients do develop chronic kidney disease. It's associated with higher mortality. Actually, the 10-year mortality excess is more than 47%. Chronic kidney disease basically leads the increase in hospitalization. It has a high burden to the healthcare system. So it's actually very difficult to deal with chronic kidney disease as a nephrologist and as an internal medicine. At the same time, and basically the most common cause of chronic kidney disease is diabetes. The second commonest cause is hypertension. Okay? So as you already probably know, the chronic kidney disease is defined by two major categories. The first category is by GFR. The second category is by albuminuria. So as you can see here, the lower the GFR, the more likely your patient is going to progress. And the same thing, the higher the proteinuria, the more likely your patient is going to progress. So when you're talking about the colors, what does the red and orange mean? That your patients are more likely to progress toward end-stage renal kidney disease. Okay? So how would you define chronic kidney disease? Based on the latest critical guidelines, chronic kidney disease is defined by either decrease in the GFR and or albuminuria more than 30 milligram per gram. That's persistent for more than 3 months. Okay. So again, reduced GFR and increased albuminuria are actually independently associated with increased cardiovascular death and kidney event. As you can see here, the higher the GFR, the higher the hazard ratio. The lower the GFR, the higher the hazard ratio. The higher the albuminuria, the higher the hazard ratio. Combined together, the cardiovascular death hazard ratio is 5.9. Kidney event here is defined as any death that's related to kidney disease. As you can see here, the lower the GFR, the higher the hazard ratio. The higher the albuminuria, the higher the hazard ratio. So when you're talking about chronic kidney disease, the higher the stage or the lower the GFR, the more risk or the higher risk you're dealing with. Okay? So in comparison to patient with normal kidney function, you can see that any patient with chronic kidney disease, they're more likely 4 times the rate of hospitalization. And if you look, for example, stage 4 and 5, in comparison to no kidney disease, they're 12 times the rate of hospitalization. So again, they have a higher rate of hospitalization. Okay? So EMBA kidney trial was involved in 8 participating countries. I mean, North American countries were US and Canada, from Europe, UK, Germany, and Italy, and from Asia, China, Malaysia, and Japan. So it's actually from 3 major continents worldwide. The majority of patients came from Europe, and 26% of the patients came from North America. Okay. So in terms of the clinical trial itself, it's actually a phase 3 double-blinded placebo-controlled trial. The way it was designed, basically the treatment group received empagliflozin 10 milligram once daily, in addition to the standard care, which we know as a physician ACE, ARB, or diabetic medication if they're diabetic, and hypertension if they're not, if they are hypertensive. In addition, the placebo arm received placebo in addition to the standard of care. So the primary outcome was composite outcome. So it wasn't like a single outcome, it was a composite outcome. What I mean by that is basically if the patient developed either kidney disease progression or cardiovascular death, this is considered achieving primary outcome. And the kidney disease is defined either reaching end-stage renal disease or kidney function loss. That's sustained reduction in GFR more than 40% or GFR less than 10 throughout the study. And once the primary outcome is achieved, they try to look at secondary outcomes. So the secondary outcomes they defined as all-cause hospitalization, first occurrence of hospitalization for heart failure and cardiovascular death, and all-cause mortality. So any cause of mortality, not just related to cardiovascular death. Okay? So the inclusion criteria, they include adult patients, but they mainly focus at patients with chronic kidney disease that are high risk for progression. They just didn't take any chronic kidney disease. The patient with more likely to progress in terms of their kidney function. So they basically focused on patients with GFR more than 45 and less than 90, but they have a moderate proteinuria, more than 200 milligram per gram, and a GFR more than 20 and less than 45. So that's the category of patient they include in the study. And in addition, they actually looked if the patient were clinically on appropriate dose of a single dose of either ARB or ACE, and they made sure that neither requires SGLT inhibitor, nor that such a treatment is inappropriate for the patient. In terms of exclusion criteria, they made sure the patient currently, if the patient is currently receiving SGLT inhibitor, they were excluded. Patient with atherosclerotic disease, but they had a GFR more than 60, they were excluded. Patient who were receiving a dual, basically RAS inhibition, ACE and ARB, they were excluded. Any patient who actually received immunosuppression therapy more than 3 months, less than in the last 3 months of the analysis period, they were excluded. And any patient who were on maintenance dialysis had functioning graft, renal transplant graft, polycystic kidney disease, and type 1 diabetes. I just want to mention, in this trial, they actually included type 1 diabetes initially. So at the beginning of the trial, patients with type 1, they were included. And later on, FDA rejected empagliflozin and dapagliflozin to be as an indication for type 1 diabetes. So initially, they were in the trial, and it showed in the study, I will show you later on, but later on, it became exclusion criteria. Okay, so this is just showing you the primary outcome. Again, it's a composite outcome, so either kidney disease progression or cardiovascular death. Once this primary outcome achieved, they actually try to look at the statistical significance. If it's statistically significant, they proceed and looked at the secondary outcome. And these are all-cause mortality, all-cause hospitalization, and first occurrence of heart failure or cardiovascular death. Okay, so this is what I show you. So they try to actually focus on this group of patients. The group in the triangle, they consider to be in risk of disease progression. So they actually did not focus on this group. They did not focus on this group. They focused actually on the group in the middle, where they actually believed to have increased risk of renal progression. And to keep in mind, these patients were not just diabetic patient diabetes, with diabetes and without diabetes, the patient with chronic kidney disease, as I show you later. Okay, so this is actually the summary of the study. Overall, they had 6,609 patients and 3,305 in the placebo arm, and 3,304 in the empagliflozin arm. The loss of follow-up is actually minimal, as you can see here, and overall, 99% of the participants in both arms completed the study. The final follow-up were completed in July 2022 with more than 90% follow-up and a median follow-up of 2 years. Okay, so this is just showing you the baseline, and looking at both arms, you can see that there is a good randomization. So both arms, they look similar in actually in terms of age, gender, and even in terms of chronic kidney disease causes. So if you look at diabetic kidney disease, like almost 31% in the empagliflozin arm, and the placebo arm 31%. The glomerular diseases is actually 26 and 25%. So overall, it's fairly similar groups. So it's a good randomized trial. Okay, so this is the same here, looking at the race. So a majority were actually white. However, black were involved. Other races were involved. I just want to say, as mentioned earlier on, if you look at type 1 diabetes, there was 34 participants in each arm, the empagliflozin and the placebo. They were initially included, but based on the FDA recommendation, they were excluded due to the risk of basically ketoacidosis. So this is also the baseline group. Okay, so looking in summary, overall 6,609 patients were randomized. At the baseline, 54% had no history of diabetes, 27% had cardiovascular disease. With regard to the kidney outcome, with regard to the kidney baseline, 35% had a GFR less than 30, and 48% had albuminuria less than 300 milligram per gram. If you look at the kidney primary diagnosis, diabetic kidney disease were only 31%, and if you look at the glomerular diseases, they're 25%. So overall, it was actually tested for chronic kidney disease, regardless of the cause, whether the cause is diabetes or not. Okay, So this is showing you the outcome, the primary outcome, which, as I said, is the chronic kidney disease or cardiovascular death. If you look at the hazard ratio, 0.72, that's a significant confidence interval, resulting in a risk reduction ratio of 28%, and the number needed to treat at 28. So this is statistically significant. Overall, there was 432 patients achieved the outcome in the empagliflozin group, and 558 in the placebo group. So this is, as you can see, after almost 1 year, they started to separate. Looking at the secondary outcome that was statistically significant, the hazard ratio is 0.86. That's, again, statistically significant. Looking at the confidence intervals and the p-value, there is a reduction of 14% in the empagliflozin group, and overall, there is a decrease of all-cause hospitalization. Okay? This is the secondary outcome, which is the first occurrence of heart failure and cardiovascular death. If you look here, it's not reaching statistical significance. Yes, there is a separation in both lines, but it's not reaching statistical significance. So yes, the hazard ratio is low, as you can see, 0.8, but it's not statistically significant. And the same thing for all-cause mortality. You can see there's a separation with a hazard ratio of 0.87, but it's not reaching statistical significance. So in summary, if all-cause hospitalization, there was a reduction with the statistical significance. The hazard ratio was 0.86. For the heart failure, cardiovascular death, and death from any cause, yes, the hazard ratio is low, but it's not reaching statistical significance. The confidence intervals, as you can see here, is not significant. Okay? So this is just showing you the subgroup analysis of the primary endpoints. As you can see here, I just want to focus on the proteinuria. So if you look at the overall outcome, it's statistically significant. That's for the primary outcome. But just focus on this part. You see the patient who benefited the most is patient who have significant proteinuria more than 300 milligram. As you can see here, this is statistically significant. While patient with moderate proteinuria, patient with mild proteinuria increase, they did not benefit the most, and the confidence interval is not statistically significant. So this is also other subgroup analysis. As you can see, overall, it's favoring the empagliflozin. And this is also another sub-analysis focusing on the diabetic kidney disease and glomerular diseases. They're reaching statistical significance, and they favor the use of empagliflozin in this group category. For patients with hypertension, renal vascular disease, and other unknown causes, the hazard ratio is low, but it's not statistically significant. But overall, if you look at the line here, it's all the subgroup analysis favoring empagliflozin. Okay, so that's all-cause hospitalization. Again, this is the only secondary outcome that's actually statistically significant. As you can see here, is 0.8, and all the subgroup analysis favoring empagliflozin. They tried to actually look at the tertiary outcome, and the tertiary outcome at that time was the mean GFR. So they called the chronic slope GFR, but what they did, basically, they calculated the difference of mean GFR between the empagliflozin and the placebo, and they calculated the difference. And you can see here it's minus 1.37 and minus 2.75. But what they did, the way they calculated the difference here, they avoided the initial drop of the GFR. That's usually expected with a patient with SGLT inhibitor. So they actually calculated the difference after 2 months. And that's the difference. And later on, what they did, basically, they took the total slope. So in the top one, they actually looked at the initial change in GFR until the end of the follow-up. The chronic slope, they just they avoided the first 2 months to avoid this drop of the GFR that's expected with SGLT inhibitor. And they actually looked. Both, there is a difference. But after 2 months, there's a more difference. And if you look at the confidence interval, in both, whether it's a total slope change or a chronic slope change, the confidence interval is actually statistically significant. So it's achieving its goal. So that's just showing you the subgroup analysis of the change in the GFR's slope. As you can see, it's all favor empagliflozin. Okay. So summary of other secondary outcomes. So they try to look at the secondary outcomes. So if you notice here, is kidney disease progression and death from cardiovascular causes. So actually, if you combine them together, they are the primary outcome of the study, which was statistically significant. So they look at them individually, separately. They took the kidney disease progression and the disease from cardiovascular death. You can see that for disease progression, it's statistically significant. But for the death from cardiovascular causes, it's not statistically significant. So if you take them together, this is the primary endpoint, and it's statistically significant. But if you take them separately, it's only the kidney disease progression that's statistically significant. The same thing with end-stage renal disease dialysis. If you look at the hazard ratio, it's statistically significant. So it seems that empagliflozin is it's actually good at reducing kidney disease progression. There is a reduction in mortality by itself, but it's not statistically significant. Okay, so the same thing here. If you look at the disease progression overall, it favors actually kidney disease progression. It helps. It's all statistically significant, except the death from renal causes. If you look at this confidence interval here, it's not statistically significant. So other than that, all favor empagliflozin, and they are statistically significant. Okay. With regard to the safety of empagliflozin, it's actually safe in comparison to the placebo. If you look at the serious adverse event, non-serious adverse event, there were less than the placebo. So if you look at the serious adverse event, it's 1.8% in comparison to 2.3%. Non-serious adverse event is 1.8% in comparison to 1.3%. So overall, like either less or similar in terms of overall safety. The same thing with serious infections, UTI, genital infection, they were actually similar. Here you can see there's no hazard ratio calculated because the number of actually event is small. Here is like 1 and 1, so it's difficult to calculate. The same thing with ketoacidosis, which is like believed to be common with SGLT inhibitor. If you look here, it's only 2 and 1. So again, it's a very small number. That's why they did not calculate the hazard ratio. But overall, if you look at the hazard ratio, there's no difference between the two arms, the empagliflozin and the placebo. In terms of causes of hospitalization, again, there is no difference except the top one, which is the surgical and medical procedure, and it's even higher with the placebo in comparison to empagliflozin. So overall, they had similar causes of hospitalization. Okay, reason for discontinuation. Again, any reason for discontinuation is 16.9% in comparison to the placebo. Overall, favors empagliflozin. Okay, so in summary, EMBA-CKD actually stopped early due to the efficacy and showing that this drug is efficacious with the renal progression. It showed that empagliflozin reduced relative risk kidney disease progression or cardiovascular death as a composite outcome in these patients. And the same thing for the secondary outcome, it showed a statistically significant reduction of 14% only for all-cause hospitalization. So overall, these are the main point and the main summary from the EMBA kidney trial. It's useful for kidney disease progression and cardiovascular death as a composite outcome in the initial group that we mentioned in chronic kidney disease patient with GFR less than 45 and proteinuria. And the same thing, if you look at the safety of the data, it's actually considered to be safe, and we already have a good it already has a good safety profile. Okay.